Good morning, everybody. This is Dr. Heather Herdman, and I am hoping that you are here for the presentation on changes to NANDA International's use of multiaxial structure for our diagnoses. Specifically, we're going to be talking today about changes that are being made to bring the NANDA structure more in line with the International Standards Organization's use of axes within diagnosis for nursing. So they have a particular way of developing the way that diagnosis should be represented in electronic health records, for example. And so we want to make sure that we are in compliance with that. And so that's what we're going to be talking about today. So you will notice that you have available to you a question and answer box at the bottom of your screen. And please feel free to put questions in there. And then when we get to the end of today's seminar, we will do our best to try to answer the questions that you have. So without any further ado, we're going to go ahead and get started because we have a lot to get through. As we start, I just want to make sure that we're talking about the same thing. And so it's always good to have operational definitions. We know this from our diagnoses. It's important to have a very clear definition of a diagnosis. And it's very important for us to be very clear that we're all talking about the same thing as we move forward today. So I want to make sure that we're on the same track here. So assessment on several axes. It refers to different domains of information that can support the nurse in diagnosis, in predicting outcomes, and in planning activities, actions, interventions. And the purpose of multiaxial diagnosis is not for us to co-join terms at the bedside and pull a term from this axis and pull a term from this axis and put it together and we have a diagnosis. Because of course, that would mean we don't have definitions of that diagnostic term, nor do we have diagnostic indicators for that term. But it does help us to direct our search for terms that represent our judgment. And this is really important to remember because a diagnosis is not a label that is meaningful outside of assessment. We must have a very solid nursing-focused assessment to drive our diagnosis. And so a multiaxial design allows us to have more of a kind of comprehensive diagnostic snapshot, a picture of the patient who's receiving our care on a variety of foci. And so that's what we're going to talk about today as we move forward. So definitions. What is an axis? The International Standards Organization doesn't actually provide a definition for what an axis is, but within NANDA International, we do. And so we define an axis as a system of classifying human responses according to several categories of factors. So these could be social and cultural influences. They could be physiologic influences, as well as clinical symptoms for the purpose of our taxonomy. We operationally define an axis as a dimension of the human response that is considered in the diagnostic process. I think that's very important. The purpose here within the axis, or within the NANDA definition of axis, is that it's something that helps us as we are considering our diagnostic hypotheses. Is there something within these axes that can help us validate clinically a diagnosis as we are working through the diagnostic process in our minds with our patients? So within our multiaxial structure, we have 7 axes in the current definitions and classification books that you may have on your bookshelf today. The first is the focus of the diagnosis. So this is the what we might call the concept. What is the conceptual underpinning of the diagnosis we are considering? So, for example, it could be something such as tissue perfusion. It could be coping. It could be grieving. These are the areas of focus when we're starting to think about, is this diagnosis appropriate for the patient? Is it reflecting and representing the response I'm seeing from my individual patient? It's not just picking something off a list, but does this term that is defined represent what I'm seeing in my patient? Axis 2 is the subject of the diagnosis. So here it's the person, it's the family, it could be a community, it could be an informal caregiver, for example. So this is, who are we talking about when we are considering this diagnosis? This seems obvious, but it can get kind of tricky, especially with some of the diagnoses around, for example, nutrition in infants. Because some of the characteristics, some of the defining characteristics or the related factors even may be more specific to the individual who is feeding the infant, and some of them are specific to the infant alone. So then the question gets asked sometimes, well, who is the patient here? Is it the parent who's feeding the baby, or is it the baby who is getting the food? And it's really important that we're clear about who we are talking about in those definitions and in our axes terms. Judgment is, what is it the nurse sees? Am I seeing that there is a process that is not as effective as it should be? And therefore we could call that ineffective. Am I seeing a potentiality in a patient? So this is a person who has the ability and the desire to move beyond their current state of health to a better one. So judgment terms help us to identify, is it a problem? Is it a potential risk diagnosis, or is it a potentiality or a health improvement diagnosis? Our fourth axis is location. So this currently is things such as bladder, cerebral. This is one of the axes that we've often had confusion around because of there's a variety of levels of granularity in our current location axis. So we'll talk about that a little bit more. Axis 5 is age. So this is currently identified as infant, neonate, child, adolescent, adult, young adult, old adult, elder adult, etc. Our time axis is about the diagnosis itself. So is this a chronic condition? Is it an acute condition? Is it an intermittent condition? That's where the time axis can help us. And then finally, the status of the diagnosis. And the status as it stands currently is this a problem-focused diagnosis? Is it a risk diagnosis? Is it a health promotion diagnosis? So these are our current diagnoses. And you can see on this slide our current modeling of the NANDA-I representation of a nursing diagnostic judgment in this format below, which is similar to what we see with the International Standard Organization. So why do we care? What is the purpose of this? And I have students ask me this all the time. Do they have to memorize the axis terms and definitions? The real goal here is to provide nurses with a way of sifting through a lot of data. So when we're starting to look at our assessment data and all the questions we've asked and all the data we've collected, how do we identify what data or what information applies to this patient that's in front of us right now? And then how do we identify the terms that most closely map to or relate to what the phenomena is that we are seeing in clinical practice? So in this way, axes can help support our clinical reasoning. Within electronic health records or within electronic apps, for example, it can actually help support us in a way that as we are adding more and more information, it can help us narrow down more possible or more probably relevant diagnoses based on the axis terms and what we've identified in our assessments that link to those axes terms. So a couple of years ago, when we started this project, we began by meeting with a taxonomist. And the taxonomist was somebody who works with nursing terminologies and helps us to clarify and make sure that we are kind of following the rules of taxonomic structure. And her first direction to our group was, you need to clean up your axial terms, the current terms that you have. Her actual words to us were, you have too many terms, they are redundant, and they're non-differentiated between axes, meaning that we had overlap in terms that maybe crossed more than one axis, which should not happen in taxonomic structure. So then I spoke with some informaticists that work with NANDA and who are colleagues of ours. So Dr. Gail Keenan, who's a past board member and past director of informatics. I also spoke with Dr. Karen Dunn-Lopez at the Center for Classification in Iowa, who is an informaticist who has worked with NANDA, but also clearly with Nick and Knock. As three kind of native English speakers, we soon realized in looking at our terms that they were, some of them, especially in the judgment terms, some of them were nearly indistinguishable one from another. So this corresponded to concerns that I hear every time we have a translation going on for our book, because I will have translators who will say to me, oh, can you define the difference between, let's say, hopelessness and helplessness, restlessness and agitation, anxiety and rumination? And often the words that they're asking me about are synonyms for each other. So that makes it very difficult to clearly translate and make sure that we're meaning the same thing. And it brings up an issue of why do we use all these terms that basically mean the same thing when we could clearly use one term and have it well defined and decrease confusion. So we learned that there were some rules in multiaxial structuring, and you may well know these rules. The first rule is that all terms in one axis has to be clearly differentiated from another term in another axis. So you can't have the same terms appearing in two places. Terms can't overlap. So for example, in our current age axis, we have a lot of overlap. We have definitions of fetus and neonate, and infant and child, and adolescent. Now, in adolescent, we're saying 10 to 19. In child, we're saying anybody under the age of 19. But then we have infant, which is a child who's less than a year. So as you can see, all of those three things, adolescence, child, infant, could be contained in our term child, because the age limits or the definitions of those terms all fall under that larger child term. Now that's difficult because there are times when we really want to differentiate a neonate, for example, from a toddler, because the responses are different. The causes of a diagnosis might be different. So we'll talk about that as we get to that axis, but it is important that they don't overlap. So these are three of the key things that we have to really do as we're working on axis development. Okay, so what you see in front of you here is the current International Standards Organization model for a nursing diagnosis. And you will see that there are more boxes in this model than in the NANDA model. And it's not exactly set up the same way. So that's important to acknowledge. And we'll look at them side by side here in a moment. But within the ISO model, you do have the degree So the degree, which is the relative severity or intensity of a diagnosis. And this is up in the top box up here in the left-hand side. We're looking at degree. Went ahead there. Clinical course is another issue that we have, and that's related to onset of a diagnosis, but also the duration of the diagnosis. So for example, our acute, chronic, intermittent. It does not include time-related expressions, though, such as duration at the current moment. We don't have that. And then we have timing. Timing is descriptors that are used for like things. For example, a term might be morning nausea. So morning is not a specific point in time. It's not 8:01 a.m., but morning is a period of time that we can all agree we pretty much understand. So it could be morning nausea. And in that case, we would say that the occurrence is the period of time that is known as morning. Okay. And then we have subject of the information. So subject of information here, just as with NANDA, is the type of entity to which the diagnosis refers. So are we talking about the person? Are we talking about the family? Are we talking about the community? We then have potential, and potential here is associated with judgment. And that is, a capacity for occurring. So we are making a judgment about whether or not the patient or the family or the community in front of us has the capacity, has the ability, in some cases has the desire to increase something. So to increase a level of knowledge, for example, or to increase a level of wellness. So this is what we look at when we're talking about potential. And then we have, of course, a chance for. And a chance for is kind of part of potential. So a potential for a positive diagnosis is a chance. So potential, you have the potential to be better. You also have the potential to get worse. So underneath potential, we have chance for, which we think of in NANDA as our readiness for enhanced diagnoses. So our health promotion diagnoses. And then you can have a risk for, and that's a potential for a negative or a problem-focused diagnosis. So those would be our risk diagnoses, because we are identifying, we're making a judgment that a patient has a risk for bleeding, and a risk for ineffective breathing pattern, whatever it is. So these are both two types of potentiality. Over on the left side here, we have clinical finding. And clinical finding is a single descriptor or a focus and a judgment, but it generally is preferred, and ISO strongly prefers that it is the focus. So it is a descriptor about what it is we're seeing. And the focus is the area of attention. So this is an either or as it's set up right now in ISO. You can either have a clinical focus, a clinical finding. An example of that within the current NANDA taxonomy would be any of our terms that have one word in our labels. So anxiety, fear, nausea, those things that are one word, they are combining the focus and the judgment in one term. And the preferred method is that you have a focus plus a judgment. So here you have the area of the concept, the area of attention. So for example, we would have coping as an area of attention, and then the judgment term, which could be ineffective, or it could be readiness for enhanced, or it could be, maladaptive. So this is where you have the focus term, that area of attention, plus the judgment term. This is the preferred method of presenting a diagnosis. And you will notice in the new edition that we worked very hard as a huge group of people to try to move our terms into line with focus plus judgment. And then we have sight. So sight is now called anatomical sight. So this is a change in the terminology within ISO that doesn't exist in their current map. They haven't changed the map yet. It is specifically about a body. And the reason that they changed this to say anatomical sight was there was confusion and people were using, for example, outpatient as a site, or perioperative or operating room as a site. That was not the intent. So we are strictly looking here at a body component or structure when we're talking about sight. Okay, so that's a very quick and dirty walkthrough of what we have with ISO currently. And then here you can see at the top, we have the current ISO model, and at the bottom, we have the current NANDA model. And this is just a way for you to kind of see how they line up against each other. In our current model, you see that we have axis 1 as the focus of the diagnosis. So this is the concept, the principal element or fundamental part. Some people might call it the root of the diagnosis and the diagnostic concept. And it's important that the focus describes the human response that is at the core of the diagnostic statement. We have axis 2 at the bottom. This is the subject of the diagnosis here. And axis 2 is the person or group for whom the diagnosis is intended. So again, individual, family, community, etc. Axis 3, which is the top right, is our judgment. And judgment is the descriptor or modifier that limits or it can specify the meaning of the focus of the diagnosis. So is the meaning that there is a problem, that there is a deficiency, that there is an excess? Is the focus that there is a risk? Is the focus that there is potentiality there? We then have age. Age is, as you notice up here, it is not part of the ISO model, but it is part of the NANDA model. And we have kind of put it inside of the subject of the diagnosis. So inside of axis 2, it's kind of underneath that umbrella, but it is its separate axis. And here it's the age group of the person who is the subject of the diagnosis. Our 6th axis is time, and this is the duration of the focus. So this is acute, chronic, intermittent. And again, it's kind of clustered underneath that judgment axis because it's part of the judgment. It's something you're considering as you're considering the judgment itself. And then our axis 7, also in that judgment area, is the status of the diagnosis. And this is equivalent to the terms NANDA uses for problem-focused, risk-focused, or readiness or health promotion focused. So that's just a quick comparison of the NANDA model to the ISO model. All right, so let's start to think about these focus terms or these judgment terms that we're needing to look at. And when we think about a focus or what is the concept of interest, one of the questions that one of the taxonomists suggested that we think about is when you're assessing your patient, when you're walking through the assessment that you're doing, what is the thing you think about first? What is that thing that just kind of pops into your head? And is it that you're like, oh, I'm seeing this patient has some self-care issues. So self-care might be the primary focus. Or I'm concerned about the nutritional status of my patient. So nourishment might be that first level term. I'm worried about the cognitive function of this patient. And then cognitive function might be that primary focus term. So if we think about that primary focus term as what is it you think about first as you are synthesizing and as you're considering the data that you have collected. And this is why it's so important that you can't just automatically link a nursing diagnostic label to a medical term, because we might have 10 patients that all have a myocardial infarction, but the primary focus terms that we're thinking about the patients that are in front of us could be 10 completely different primary foci. So we might have one person who has, a respiratory function issue. We might have one that has a cardiovascular function issue. We might have one where energy level is the primary concern. We might have one where fear is the primary concern. So it's what is it you think about first as you're synthesizing this information you have gathered about this patient. And these are just some examples here of some of our primary focus terms that we have identified now within our terminology. So these are the current primary focus terms that we are working with. And the way that we are adding to and or subtracting these focus terms is as we look at diagnoses that are being developed and refined. And as we really start to say, well, what is the underlying concept here? What is that first aha moment that you would get as a nurse if you saw this pattern that's represented in the data? So that's our primary focus term. So we then have secondary focus terms. In secondary focus terms, the question the taxonomist put to us is, okay, so now you've identified that there's something with this patient's behavior that is not, it's not, let's say, homeostatic. It's not balanced. It's not a healthy behavior, perhaps. And what is it about that behavior? So what is it now that we know it's behavior that's the focus? What do you think about next? What type of behavior is it? Is there something specific here that can help us to understand what's going on with this patient? And so these are just some of the examples of secondary terms that we have identified that could come under behavior. So we could have behaviors related to decision-making, behaviors related to health maintenance, to literacy, to parenting. So we might, the thought process might be, as you're looking at data or you're considering the assessment you've completed, there's some behavioral things that I think we need to deal with. Well, what are those behavioral things? Well, I think they're related to trauma. I think it's related to the trauma that this person felt or experienced. So we might be looking at post-traumatic behaviors in that case. Or it might be, this is a person who is really having difficulty in life right now. They're seeking some kind of control in their life. And what's coming out, what's being seen is that they are really severely limiting their eating. They're putting very, very tight strictures around what they will and will not eat, when they will and will not eat, how much they will and will not eat. So the behaviors of concern might be related to eating pattern, for example. So this is a way of further kind of drilling down into the data that we see with our patients to help us better clarify what type of behavior we may need to intervene upon, or we may wish to intervene upon. Excuse me. So judgment terms. In the current book, you will notice that we have this table, and the table has 34 judgment terms. The judgment terms, again, are those modifiers or descriptors that limit or specify the meaning of the focus. So this is well, what is the judgment? Is the judgment that something is functional? Is the judgment that something is excessive? Is it that something is decreased, defensive, etc.? So right now in the book, there's 34 of these terms. And if you take the time to really look at the definition of these judgment terms, there is a significant amount of overlap in those terms. So, for example, what I have highlighted here are the terms deficient, deprivation, inadequate, insufficient, and low. So 5 terms, all of which indicate a reduction in amount, in intensity, in degree. And these are questions that I get all the time from our translators. How do I differentiate insufficient from deficient? What's the difference? And to be quite honest, if we go back and look historically, and I'm guilty of saying this myself, sometimes we'll say, oh, it sounds better in English if we use insufficient than deficient. So there's kind of a grammar police in our heads saying, we would never say that. But we have to remember that that's not the purpose here. The purpose is to better define our terms, to make them as clear and as easy to validate as possible. So we really need to focus in on what is the best judgment term that can cover all of these 5 terms, rather than having 5 terms that are really difficult to differentiate one from another. Another example here is we have compromised, disturbed, impaired, ineffective. All of these would indicate that something in our body is not working as well as it should. So again, how do we differentiate these? And are there better ways to either define them so that they are very clearly different, or combine them into one term or a couple of terms that can reflect these 4 terms? So these are some of the issues that we have been grappling with over the last couple of years around judgment terms. And honestly, they're the ones that have taken the most time and have been the most difficult to manage. So right now, this is where we are sitting with judgment terms. And I say right now, we are in the process of finalizing the taxonomy as we speak. We're already in first drafts of looking at that taxonomy. So we're pretty close, we think, but we started with 13 and we have added 2, and that has been because either new diagnosis that came in after the original draft was done that just didn't fit in the terms that we had, or as we were working with these terms, we started saying, yeah, but you know what, that doesn't really fit in this other term, and we really do need this other term. So right now we have these 15 terms. The definitions are still in draft form, so they may change. They may well change before the book comes out. But this does at least give you some examples of what we're thinking about. And you can see that we've decreased the number of terms by more than half. So we went from 34 and now we're sitting at 15. So I think that you will find that this is helpful. It's certainly going to be helpful for the translators, but it should be helpful in us ensuring that we are using the same terms in the same way in all of our diagnoses. So that has a definite benefit. Okay, so then we have location. Location in the ISO model, as you can see at the top, is not there. There's nothing underneath that site box, and it's called site, versus we have the location axis. So we call these things 2 different things, location versus site. Some of the proposed locations bring up some difficulty with granularity. So for example, if you look in our current location list, if you look at the table in the book that shows all the different locations that we have, you'll see that it's parts and regions and et cetera of the body, but some of them are very specific, such as mouth or eye, and others list a system, such as gastrointestinal system. But then you may also see gastrointestinal tract. So there are varying levels of granularity in our current locations. And so we've been working to try to address this issue as well. So just to give you some examples, we have 23 locations currently. And as my point here, in the yellow, you'll see bowel, gastrointestinal, liver, and mouth. Now, all of those belong to the gastrointestinal system, except mouth, you could argue, also could belong to the respiratory or cardiopulmonary system. But do we really need bowel when we could have gastrointestinal? The next one down, we have breast and we have nipple areolar complex. Well, the nipple areolar complex is a location on the breast. So do we need both? Or do we roll those up to a higher level of, reproductive system or genitourinary system? We have cardiac, cardiovascular, vascular, venous. Again, all of those could be incorporated into perhaps cerebral vascular system or peripheral vascular system. So these were other issues we grappled with, like how granular do we want to be? Do we really want to have a list that says, the left finger of the left hand at the proximal digit? I mean, do we really want to get that specific with location? Or are we simply trying to focus the individual, help them weed through assessment criteria and say, the majority of my findings are coming up in the lymphatic system or in the integumentary system? So after a lot of different options and trying a lot of different ways, we have settled on a higher level anatomical location. And so we have gone with system levels. So you can see here, we have 8 identified on the right-hand side, and these will have obviously very clear operational definitions with them as well. But again, this is a way of kind of helping to move that data into a funnel and get it compacted into a way that we can better categorize it in our minds and better drive good decision making. So changes there. Here are the definitions as they stand right now. These, we think we're pretty happy with these. We have one more pass through of these definitions to look at, but right now this is kind of where we're sitting with the location axes, or the anatomical location axes, as ISO calls it. And then we have degree. So the question about degree has been a really, really interesting one. And I think it's something that NANDA International really needs to take some time to consider and to debate in terms of, what do we do? How do we address degree? So by degree, what I mean here is, what is the relative severity or intensity of a diagnosis? This conversation came up as ISO was looking at its own revision for the nursing diagnostic model. And a question was raised, well, is everything a risk? And how do we know what kind of a risk it is? And how do we know how much attention we should pay to this particular risk? So are all risks equal, for example? Or could we start to say, this patient is at a mild or a low risk. This person is at a moderate, risk. This person is at a high risk or a severe risk. And certainly there are diagnoses where we can do that. We are at a point where, with falls, for example, or with pressure injury, we can identify on using, very well researched and clinically validated instruments what the level of risk is for an individual based on, findings from a particular assessment tool, for example. Some of the questions would be, does it make sense to always have a degree of risk? so do we have a severe risk of ineffective coping? And is the differentiation of severe from mild ineffective coping, for example, is it in some way going to change the outcomes or the interventions that we would use? Does it change how we plan our care? Because that's really critical. We can we could come up with categories and say this is a mild, moderate, severe risk for everything, but does it help our care? Does it improve patient outcomes? That's ultimately what we're here for, right? So the question is, how do we want to handle risks? Do we want to look only at things that have, categorical data behind them, that have, validated instruments that can put your risk on a spectrum? How will we handle it and what will we do with it? There's pros and cons to maintaining kind of a generic risk category. And we really need to think it through, what it would look like and what would be the pros and what would be the cons of stipulating a level or degree. It's probably on the clinical physiologic side, there could be times when it could be quite helpful. And we could reduce the list of risk factors or defining characteristics if we knew that, we're looking at high risk here, because high risk, there might be a shorter list of things that really put you at high risk for XYZ diagnosis. If those things don't change, though, if you still end up with the same defining characteristics and the same related factors, we might say, what's the point? So, if we're able to clearly differentiate mild from moderate from severe, this probably takes us closer to what Marjorie Gordon used to say, which was that, there are probably 3 or 4 critical defining characteristics, critical risk factors that must be present for you to make a diagnosis. But we still have the question of, can we differentiate degrees for all diagnosis? And the answer to that is probably not, or at least probably not yet. So this is something that personally I would like to see NANDA grapple with over the next couple of years and make some decisions so that we can provide directions to those of you who are in the field developing and testing these diagnoses as to what is it we would like to see in the degree category. So again, just kind of taking us back to, here's where we are with the current ISO categorical structure for nursing diagnosis. And what is it that, that ISO is looking for in a representation of the judgment the nurse makes about a particular patient group, family, community, for example. And then we can compare this to our new draft. So this looks a little bit different in terms of words than what you saw at the beginning, in that we have changed location to anatomical location, so axis 4. And we have added an axis 8. And axis 8 is a situational constraint. So here we have, in the overall field, we have the primary and secondary field of focus, the primary foci of the diagnosis, where before we just had focus of the diagnosis. So we've split this down so that you can kind of have, here's what I think of first, and then here's what I think of second. That's the focus, axis 1. We have changed time to clinical course, and this is axis 6. And this is, again, to keep with the terminology that's being used by the International Standards Organization. So clinical course, maintaining our current descriptors of acute, chronic, and intermittent and continuous. So we just changed the label of the axis, but the descriptors have remained the same. And this remains nested within that judgment axis, along with the status axis, which is axis 7. Age remains nested under subject of the information because it's refers specifically to the subject of the diagnosis. And we have renamed subject of the information to, again, be consistent with that's what ISO calls it. So that's what we're going to call it. Age is an interesting axis because the overlap there seems to be kind of more normal than not. So there's a lot of overlap in those categories if you look at them. I mentioned earlier infant and baby, but you can also think the same thing on the other end of the spectrum where we have adult, but then we have older adult, aged adult. All of them are still adults. So how do we differentiate that? And after a lot of thought and going back and forth, and because ISO does not itself have an age axis, we are moving toward definitions that have an upper and lower limit. So we're not going to necessarily use terms. We're going to use actual numbers. So the lower limit for a diagnosis might be the age of 10, for example, but it might go until, there may not be any higher end. It could be 0 to 28 days. So if we're trying to reflect the neonatal period, we might say this diagnosis is specific for individuals who are between 0 days of age and 28 days of age. So that's how we're handling the age axis moving forward. Situational context, this is the new axis. And these are defined as a physical location, a situation, or an environmental condition that could support a judgment. So for example, we had a lot of terms in our current axes that included things such as bed, wheelchair, or reference to operating room or theater through perioperative, for example. We had situations such as support surfaces or sitting position, standing position. And then we had environmental conditions such as temperature extremes. And the feeling is that those things can be very helpful. These contexts can be very helpful as we're considering diagnoses for patients. So we didn't want to lose these things, but they no longer fit in the axes as they were being refined and defined. So we identified this situational context, and it is here that you will find these physical locations, situations, and environmental conditions. And so this is a new thing. It will take us some getting used to in terms of whether we want to how we use it, when we use it, et cetera. But we do believe that it will help support clinical reasoning, clinical judgment. So that's why it's there. So that's the situational context axis. And then where do we go from here? Because we are definitely not done. This has been a 2-year process, 2.5-year process. But we know that this is, as we publish this will be kind of the first draft of our operational definitions, et cetera, for our axes. So before we publish, we have to finalize and agree on all the operational definitions for all the terms. So we will have those so that they'll be available in the book. And as I said, we're at that point right now where we are finalizing those definitions. We then have to apply the axes to all the diagnoses. And here it's important to remember that you don't necessarily have every axis represented. In fact, you rarely have every axis represented in every diagnosis. So you will see where we may have age axis and there may not be a term there. And it's not because we overlooked it, it's because it's not relevant to that term. It doesn't help you, doesn't specify anything that can help you kind of filter your data. And the goal of this first release will really be to get feedback from users. So we'll be looking to see how do these terms work? How did the reduction in terms, does it help you? Or do you find that you're missing something? So as with everything, ISO is currently reviewing their terms and they're going through a revision of the model themselves. We will continuously be reviewing and refining and revising these terms as we move forward. But one of the things we will ask people who, for example, are developing or refining diagnoses is to please look at the axes terms that currently exist. And if they want to propose a different term, to please clearly explain why the terms that we have don't meet their needs. So this is like our next step. This is where we have to go from here. So I want to stop there so that we can have some time for questions, and see what people have. So please feel free to let me know what you're thinking or what your thoughts are. Joanna asked a question here about the location of the reproductive system, and then said it didn't appear in the list of systems. It actually comes under the genitourinary system. So we combined, and that seems to be, that is what happens within ICD, for example, is we combined the genital system and the urinary system together into one categorization of genitourinary, which does include the reproductive system. So that's where we put that. Slides will definitely be available to you. So we can definitely provide those. And the presentation is also going to be available. It will be on our YouTube channel, and it will be subtitled. So we will have it subtitled in Spanish and Portuguese, I believe, I'm sure. And there may be another language that I'm forgetting, and I apologize, but we do put all of our seminars up on our YouTube page, and we will announce that as soon as that's ready. It does take a little time it does take a little time for those translations and reviews to happen. So please bear with us. Let's see. We had a question about syndromes, and that I didn't discuss syndromes within the multiaxial model. And that's correct, I did not. We don't actually, syndromes are not specified outside of, or within an axis within ISO, or are they're also not pulled apart or pulled separately out in the International Classification of Diseases either. So a syndrome is, in some people would argue, to make a diagnosis syndrome is in and itself a judgment term. So we're making a judgment that this is a syndrome, that this is a cluster of diagnoses that occur together. But the focus of that syndrome would still show up as the focus. So for example, I'm trying to think of a syndrome diagnosis. We have a new diagnosis coming out on pain syndrome, chronic pain syndrome. So, and I hope that's the right term, but the pain is still the focus. The chronicity is still the time, but the syndrome is a representation or an acknowledgement that within that phenomenon of acute pain cluster all these other diagnoses. And that if we look at those in a contextual whole, we can treat them with similar interventions, and we can treat them effectively. That's what makes them a syndrome. So it's an issue of saying, we have chronic pain, we have sleep pattern disturbance, we have problems with nutrition, we have anxiety, we have fear, perhaps, maybe social isolation. All of those things are component parts of what happens in an individual who has chronic pain that is, consistent and ongoing and affects their daily lives in a multitude of ways. We can look at that syndrome in tandem. We can kind of say, let's pull all these what appear to be disparate parts together and think about, can we intervene on all of these diagnoses in a similar manner? And only if the answer to that is yes, would we have a syndrome. But a syndrome itself it's part of the diagnostic decision tree. It's not something that's an axis in and of itself. I hope that makes sense. So there's a question about how we would provide further feedback, or how you would provide feedback after the publication of the next edition. We always encourage you to reach out to us directly. the two best lines of communication related to the book are either to contact me, and my email is here on this screen, or to contact Dr. Camila Takao Lopez, who's the director of diagnosis development, but also one of our co-editors on the book. And so either of us you can reach out to. Certainly anybody on the board, you can also reach out to them for feedback. But we will be asking for feedback. We have some ideas already in mind for how we're going to solicit some formal feedback. So after the books are out, and realize that that can be a couple-year process as well, because the books will come out in English, we're guessing around April, but then it takes time for translations to come out. So we don't want to just get feedback from English speakers. We want feedback from all of our users. So we'll be consistently asking for feedback over this next three-year period of time. So hopefully that helps. There's a question about degree. So it says, you were talking about risk diagnosis. Is this not also about problem-focused diagnosis? And when it comes to prioritizing our work, I think the set of nursing diagnoses that form the care plan is leading for your priorities. Furthermore, you can score the intensity with your present outcome. That's a very good point. Degree per the ISO model is specifically about risk, however. So they are looking at the question that came up and what kind of drove this conversation was a physician asked to have all the risk diagnosis removed from SNOMED. There was a conversation about whether risk diagnosis should even exist. And the comment was, if you don't know what level of risk you have, you could say anybody's a risk for anything. And so therefore it's not clinically useful. This was the commentary. As you might imagine, there was a lot of response back to that. And that obviously did not happen, but it did bring up this conversation around, ooh, it is a good point. You know, and I have, as a faculty member, said this to students before, you know, when they say, well, my patient doesn't have he doesn't have an actual diagnosis, so a problem-focused diagnosis. And NANDA doesn't have a risk diagnosis, but can't I just make one up? Can't I just say, well, he's at risk for this? You know, and that's there's lots of answers to that question. Obviously, no, you can't just make it up because we need to know what are those risk factors, et cetera. But the question does become, couldn't everybody be at risk for everything? I mean, technically, we're all at risk for anything in the taxonomy, probably. But how high of a risk? You know, is it a strong likelihood that I'm going to get, you know, have a problem with my breathing? Or is it just, well, everybody has risk for ineffective breathing. Everybody has risk for infection who has surgery, right? And this is always one of the ones that comes up. Somebody has a surgical procedure, the diagnosis on the chart for the student is invariably risk for infection. And, you know, my comment to them usually is, okay, let's talk about this. Was there contamination of the surgical field that we're aware of in the operating room? You know, is their immune system functioning well? Is their incision well approximated? You know, did they get the medication that they were supposed to get, you know, within the time period that is specified in the OR? Did they start getting their antibiotic as they should have around the incision time, et cetera? If the answer to all those things is yes, how much of a risk are they for infection? Not saying it's not there, but is it really your priority in this otherwise healthy person who had an elective surgery, everything went well, the incision looks great? Is that really where we want to be focusing our time? Or is maybe mobility of that joint more important, et cetera, et cetera? So while I agree with you completely that being able to prioritize our work and being able to say, in this patient, these diagnoses are clearly the priority. And sometimes those are going to be risk diagnoses, and sometimes they're going to be problem-focused diagnoses. I agree that that is critically important. That isn't what ISO is referring to when they're talking about degree. They are specifically talking about the risk. So, any other last questions? Okay, great. Well, I appreciate your time. I want to be respectful of your time and end on time. So it's the 9 o'clock hour, so or 10 o'clock hour in Eastern time. So we'll stop here. But again, we will have this available for you. Watch our social media and our blogs. We will identify when they're available out on the YouTube channel, so you can go there and you'll be able to see this again if you want to watch it again, or to grab the handouts from there. And I hope everybody has a lovely day or evening, depending on where you are in the world. And we'll see you next time. Take care.